All right, so here we go. Hi, everybody. I'm Margaret Watt. I'm the co-director of the Hub. We're the regional behavioral health action organization that serves Southwestern Connecticut, which is Greenwich to Stratford. My office is in Norwalk. And so I'm really pleased that we're able to do this Narcan training today for you guys. The Narcan is coming through DEMIS, and we are asked to always include a component of opioid education and also a little bit of suicide prevention education when we do a Narcan training. So those will be the components that I'm touching on today, and I'm still going to try to make it all fit in a half an hour. While I share my screen, let me ask, how many of you have been trained in to administer Narcan before?
I have.
I have
as well.
Okay. That's
I
good.
have not.
Okay. Any others who have not?
I have not.
Okay. All right, that's good. So, you know, it's going to be, what I'll do is I'll be going through it at a pretty rapid rate to try to get through everything in a half hour. But I want to ask you all to, I guess, mute yourselves while I'm talking. I'm not going to mute you though, so that way anytime you have a question, just interrupt me, because if I'm going fast because I think maybe it's stuff you know and you don't know it, just jump in there and say, I got a question. And also after the half hour is over, I will stay on the line for a few minutes. So if anyone has further questions about sort of mental health or substance use or resources, I can answer those questions. And I'm also going to email Paris a bunch of resources after the fact to share with all of you, okay? So hopefully everyone can see my slideshow. So we're going to talk about the opioid epidemic and Naloxone, which is the generic name, and Narcan is the brand name. As I mentioned, we'll talk about opioids. We'll talk a little bit about suicide and the connection with addiction, and we'll learn how to administer Narcan. We'll also touch briefly on the fact that there are a lot of protective laws in place around Narcan, and then local resources. So to begin, opioids are, come from the poppy flower naturally. Morphine and heroin are naturally derived. And the effect that opioids have on the body is to relieve pain. So I think at this point within the epidemic, opioid sounds like a dirty word, but when you're experiencing pain, chronic pain, acute pain, post-surgical, opioids can be a really good thing. However, they are really pretty addictive in a very short period of time. Physical dependence can develop in a couple of days. Withdrawal is extreme, and so that lends itself to addiction. One thing that I've realized, I don't know if you all have, is that everyone's aware there's an opioid epidemic, but like members of the general public, including members of my family, aren't aware that some of the stuff in their medicine cabinet may be an opioid. So oxycodone and codeine are things that we get when we have, teeth out, or, you have a surgery, back pain, knee surgery, whatever. These are all examples of opioids. On the screen, you can see a list of some of the short-acting ones. Morphine is one of the natural ones. Then there are the semi-synthetics and the synthetic ones that are completely derived chemically, but to match the formula of natural ones. Among the long-acting opioids, you have things like methadone and buprenorphine, which we know are used in medication-assisted treatment. So for someone with an opioid use disorder, you can use the long-acting opioids to actually treat the disease. So the next thing is to think about how we got to this epidemic that we have now. And it's really been 3 different waves of the opioid epidemic. In the 1990s, the pharmaceutical companies were really pushing oxycodone or OxyContin and sharing the message with doctors and educating them specifically that pain could be managed fully and 100%. So there was kind of a change in the idea that, if you had a surgery, you might have pain for a few days afterwards. The idea was really, let's get rid of the pain, let's manage it, this stuff is not addictive. So doctors started prescribing opioids, and then slowly people started to see dependence, and there started to be opioid deaths. So that was the 1990s, where people got addicted initially from a prescription. After a while, what happens is the prescription drugs started to be more regulated, and it became cheaper to turn to heroin. So those who had an addiction initially to a prescribed medicine, maybe they found it harder to doctor shop and find someone who'd give them a new prescription. Maybe it was just cheaper and easier. And people started to switch to heroin, which is also an opioid, but an illegal one, never prescribed. And then the third wave of the disease starting in 2013, as you can see on the screen, was when synthetic opioids like fentanyl started coming on the market, which is much stronger than heroin and even more addictive and extremely dangerous. And now there are even more new drugs coming on the market, because the latest trend that's happening is that the cartels are producing counterfeit drugs that will look like something else. Like there are pills out there that look like Xanax, which is a benzodiazepine for anxiety and for sleep, but it's actually heroin cut with fentanyl. So they're getting very, very potent opioids out into the market in the form of something else that looks like it could be legal. So it's less sort of arrestable. And they're labeling them with things that look like you got it with a prescription at Walmart. So it's much harder to detect. But this is the newest trend right now in Connecticut. And unfortunately, a lot of times people don't actually know that what they're getting is cut with fentanyl or heroin. So it's a big concern. This graph is just to show back in wave one, where people were mostly getting addicted through prescription drugs. This is a graph that shows along the bottom how many days was your initial prescription. So if the doctor gave you like a 5-day prescription for something after like your wisdom teeth were pulled, you had a 10% chance of continuing to use. If you had a 10-day prescription, your chance of becoming a long-term user of opioids was 20%. And when you got that 30-day prescription, which actually was literally what they used to give people just for having their wisdom teeth removed, until maybe 5 years ago, you had a 45% chance of developing a reliance on it. This is just to let you know that heroin, which is the natural opioid that this all starts with, comparing it to fentanyl, I think the key thing here is fentanyl is 50 times stronger than heroin, and it's much, much, much cheaper to produce. And now one of the synthetic drugs that's out there is CARFENTANYL. And these graphs or these images are showing you the top one with the different sizes of pills, showing you how much stronger. CARFENTANYL is 10,000 times stronger than heroin. Heroin is fentanyl is 100 times stronger. Heroin is 2 times stronger than morphine. If you look at the picture of the penny, that little bit of dust next to the penny is 2 milligrams of CARFENTANYL, which is enough to kill you. It was literally designed to sedate large animals for veterinary purposes. Another animal sedation thing is called xylazine, and that was actually involved in several deaths in Connecticut last year. So because opioids relieve pain, and also depress your breathing, they just slow everything down, they chill you out, that feels good, and yet they are very addictive. It's important to just be clear about the concept of addiction. Addiction is a chronic, relapsing and remitting, but life-threatening disease, meaning the important thing is it is a disease, it's a disorder. So a lot of times when you're working with homeless individuals, and there are people out there who'll say, why are people wasting Narcan on reviving someone with a substance use disorder? They're just going to go use again. Well, anything that's chronic is something that may come back. Recovery can be a cycle of relapse and recover again, but people don't have a chance to recover if you don't bring them back to life. And that's why Narcan is so important, because you're giving people another chance. NIDA reports that in drug addiction, the relapse rate is 40% to 60%, but we all know people in recovery, and yes, maybe a lot of them may have relapsed once, twice, 3 times, and then kind of stayed stable, and some never relapse. 2 key components of addiction. One is withdrawal. So with opioids, withdrawal can be really, really miserable. I know that officially they say that the withdrawal symptoms are like like a super bad flu, maybe like COVID, and that they only last a few days. But I mean, I've talked to people who've said the symptoms lasted 2 weeks. And tolerance is the other key concept that, especially right now with COVID, we're worried about, because tolerance means you always need a little bit more of the drug to achieve the effect you used to have. And so right now, what we're finding is people are reporting fewer opioid deaths. A lot of folks who do drug treatment are saying that during COVID, during the self-isolation, people have less access. They're more likely to be using softer drugs like marijuana and less of the opioids. So the worry is that when things open back up again, which is really going to start May 20th now, it's possible that people will go back out, start accessing opioids, use at their previous level, and have decreased tolerance. And so then we're going to potentially see a lot of overdoses that we have to be ready for. So speaking of overdose deaths, just a little bit of data. Overdose deaths are now the leading cause of adult injury death. Literally, you can put car accidents, fires, and gun deaths together, and we have more people dying from overdose deaths in this country. Almost 70,000 people died in 2018. About half of those deaths were involving opioids. The good news is there was a 5% reduction in overdose deaths around 2018 because of all the laws that have gone into effect. However, in Connecticut, we had just started to see the curve decrease last year, and now it's going back up, and that's because there's more fentanyl on the market. So it's such a stronger drug and being cut into so many other drugs that even though the prescription and the access is being curbed, unfortunately, the deaths are continuing. We have about 3 people dying per day in Connecticut from a drug overdose, an opioid overdose. And here's the actual Connecticut deaths. On the left, you see the increase year by year. On the right, the table is showing that of people who died from an overdose, 94% had an opioid in them. 82% had fentanyl because it's so much stronger. But in addition, you can see total overdoses involving cocaine, almost 40%. Total overdoses involving benzodiazepines, 22%. I looked at the data, deaths over the past 3 years in our region of Southwest Connecticut. The average person who died of a drug overdose had 2.6 drugs in their system, and usually it was a combination of opioids, benzos, and alcohol. This is just to show you the yellow part of the state is the region that's considered Southwest Connecticut. That's the region we serve. Here are the towns just to show you how many people died in 2019 in each town. And the typical overdose victim in Connecticut is a white male, middle-aged, not Hispanic, using a combination of opioids and other substances. What has been apparently starting to change is that with the new counterfeit drugs that do involve opioids but look like other things, and with a recent increase in meth in the state, those drugs are more in sort of different demographics. So whereas the opioid epidemic has been more white males, we're now starting to see all demographics affected. Oops. Okay. Now I just want to talk briefly about the connection with suicide. Probably a third of people who die by overdose are actually suicides. That's based on research that tries to be conservative, but it really looks like there's a very big overlap. And in fact, if you look at people who have an opioid addiction, 20 to 30% of them already have a history of both overdosing and a history of suicide attempt. So that's that co-occurrence of the mental health side and the addiction side. So as a result, the state asks us when we're talking about Narcan to talk about suicide and make everyone realize that, you know, I'm gonna skip this slide, that suicide is something we should be thinking about with clients, but also with our own friends and family. Suicide can be prevented if you're just kind of on the lookout for warning signs and you're willing to talk to the person and broach the subject. So just to really quickly show a few of the signs and symptoms, some people really do come out and say, I'm going to kill myself. But you do hear people saying things like, you're not going to have to worry about me that much longer. You know, who cares if I'm dead? I want out. The population you all serve is obviously extremely vulnerable. When you hear things, but also see things, different behaviors, depression, anger, a sense of hopelessness, sudden changes in behavior, and if there's then any other additional kind of like trigger risk factor, like now they got fired, now they got COVID, now they're isolated from their family. All of these are risk factors that I'm sure you're aware of, and you just want to, I always encourage people, if the thought that someone's really depressed and might be suicidal, if it even crosses your mind, then you need to talk to them. There is a training called Question-Persuade-Refer, QPR, that we can do for anybody who's interested. But it really boils down to, you ask the person the question directly. You don't use any weasel words. You don't let them wiggle out of it. You don't go, oh, are you thinking of hurting yourself? You say, have you thought about suicide? Are you thinking of killing yourself? You put them on the spot to get that answer. And usually it's a relief for them to be able to admit it if they have been thinking about it. And then you listen for a while, and you don't case manage them. You don't try to solve their problems. You let them vent. And then you persuade them to get help, and you refer them with a warm handoff. You don't give someone who's potentially suicidal a number and send them off. You make a call with them, you get them to care. The image on the right side of the screen is a flyer that we have that I'm gonna send out afterwards. So those are different phone numbers for support, including the newest ones, the Disaster Distress Helpline and the new Talk It Out Helpline. Okay, I'm gonna stop and see if anyone has any questions on anything so far. All right, then I'm gonna move on to the Narcan piece. A few facts about Narcan. So Narcan is what's called an opioid antagonist. So it is the opposite of an opioid agonist. It literally reverses the opioid or the overdose. So this is what lets you revive a person from basically from death. It's like a miracle drug, brings them back. You can save the person's life. However, it's only gonna have an effect for 30 to 90 minutes. So what's gonna be really, really important is that you be aware, you might've saved them temporarily, but action has to be taken, okay? So other key facts though, it is a prescription drug. However, the state of Connecticut has made an exception for this drug above all others. You don't have to go get a prescription. There's a standing order at any pharmacy. So anyone can just literally walk into a CVS or Walgreens or whatever and say, I wanna get some Narcan, and they have an order to give you Narcan, and they can bill your insurance if you have insurance. It only works on an opioid overdose. So if someone has, if it's alcohol or cocaine or something else, it's not gonna save them or revive them from that, but it's also not gonna hurt them. There are essentially no side effects. I've never heard of anyone who's allergic to Narcan. And it's not abusable. You can't get addicted to it. So it is really a wonder drug that saves people, and there is no harm, no foul to ever attempting to use it. So when in doubt, you use it. Now, the thing about the 30 to 90 minutes, it stays in your system for that amount of time, depending kind of on your size and your metabolism. And so what's really important is to recognize that, if I overdosed on a certain amount of heroin and I have way more heroin in my system than I have Narcan, when the Narcan wears off, the heroin's still there, I can literally overdose again. Okay, so we're gonna talk about that, but that is the main reason why you have to call 911 when you suspect an overdose. Okay, also when the drug wears off, the person is going to go into withdrawal. Or actually not when it wears off. When the Narcan hits them, they're going to be in withdrawal from the drug that was in their system. This is an image to show you what's happening in your nervous system. You've got these receptors in your body that are looking for an opioid, because our bodies make natural opioids like adrenaline, right? That's why you get that runner's high. I don't, because I don't run. But so B, the little B key is supposed to be the opioid floating around your body. That's the drug you took, and it's looking for a natural receptor to slot into in your body, and that gives you that nice high. But A is the Narcan, and Narcan will fit in there and push the B opioid out of the way and stay there. So even if the opioid's still in your system, you aren't feeling its effects for that 30 to 90 minutes. I dropped off Narcan kits for you guys this morning. Important to know that you should not keep them in your car and you shouldn't keep them in a fridge. They're stable at room temperature. So just, it doesn't do any good if they're in your fridge or your car anyway, because you need access to them. So keep them with you. We gave you a little pouch that looks like this. And in the pouch, if you may not have received it yet, but there are gloves and a surgical mask, because we want you to take care of yourselves when you're administering this. There's a little card with steps to assess someone for suicidality and a couple of other cards of resources. Also, Narcan usually expires in about 1.5 years, or that's what it says on the box. It probably lasts longer than that. So if you have an older one and you don't have a newer one, feel free to use it. And this is how you use it. So in your kit, you have your box, and it's a spray. There are other forms of Narcan, but we're giving you the nasal spray because it's so easy. There are 2 nasal sprays in there. They look exactly like what you're seeing on the screen. And as you can see in the picture, you take it, you hold it between 2 fingers, and you put your thumb on the bottom, and you put your hand under the person's neck. They're lying down, right? You tilt their head way back. You stick this up into their nose. You don't spray it first. You just get it way up in their nose. So you're aiming at the sort of top of their head, and you spray it all the way in. And that's what you do. We're going to go through kind of the real response steps, but it's as easy as that. So we're going to talk now about who's at risk of an overdose that you're really watching out for, and then there's actually 4 steps to the whole administration process. Who you really want to be worried about, not just your clients, family, friends. Anyone who's a chronic pain patient is at risk of just potentially accidentally overdosing. Kids, teens, people who have access to your medicine cabinet if you don't lock it up, which ideally we all do. Senior citizens, as we know, often have many different prescriptions, many of which may be opioids, or they may interact with one another. And young adults are more likely to be using opioids than other ages. That's who's using potentially, and who may overdose are people whose tolerance has been decreased, like we said, during COVID, less access. If someone's using alone, I know you have clients now in hotel rooms. They're not congregating, so who's got an eye on them? And of course, mixing drugs with other drugs or alcohol is a bad idea. As you can see here, health issues and age and longer drug history are all risk factors. So let's say in whatever setting in your life, work or personal, you come across someone who is in some way slumped over, passed out, wherever, Dunkin' Donuts, a library, on the street, in a hotel room. What are your 4 steps? Here they are. Number 1, you call 911 first, because as you can see in the picture, you don't know. Is this alcohol? Is this a heart attack? Is this an opioid overdose? Call 911, get them on the way, because it may or may not be an overdose. And also, even if it's an overdose, you want them to be monitored after you revive them, because for that hour after the revival, if the Narcan wears off first and the drugs are still in their system, they could overdose again. So first, you call 911 in this setting. Second, you look at symptoms and see, does this look like it's actually an opioid overdose? Let's say it does, then 3, you're going to give them the Narcan, and 4, you put them in the recovery position, and you stay with them until 911 gets there. So call 911. Check for response. So you want to pretty much lay them down, and you're looking for whether this could be an opioid overdose. One of the main symptoms is that they're really pretty non-responsive. So you can really shake them by the shoulders. You can kind of slap them around. One of the things they recommend is you take your knuckles and you do what's called a sternum rub. So right here on the sternum, the bone right here, the breastbone, you rub really hard with your knuckles. And that should be uncomfortable enough to wake them up. If they still don't wake up, you can look for things like the teeny tiny pupils in their eyes, that's a sign of opioids because they decrease blood flow. The main thing that kills people with an opioid overdose is that it slows down your breathing so much that essentially you just stop breathing. So anything that looks like the respiratory system is involved is a sign. They could be gurgling, they could be foaming at the mouth, they might not be breathing, or the breaths are just really abnormal, or signs of lack of oxygen as a result. So if their lips are blue, their fingernails are blue, all of those are signs. And obviously if you see syringes or pill bottles or something, that's another sign. So now you've decided that it's probably an opioid overdose, or maybe you're just not sure and you still think, should I administer Narcan? Yes, because it can't hurt. Now you're going to administer it. So once again, you position their head, hold them up by the neck so that their head kind of falls back so the breathing is open. Put your fingers on that and depress, stick it up their nose and depress it and spray it right up their nose. And then you're waiting a couple minutes then you'll go into the recovery position. But the other thing is, if they don't revive within 3 to 5 minutes, you are going to take your second dose and administer that to them in the other nostril. They say in the other nostril, I don't think it really matters which nostril because our nostrils connect at the bridge of our nose, right? So you have 2 doses. People who have overdosed on heroin, probably 1 dose will revive them. On fentanyl, sometimes they need 2 or even 3 doses to revive them. But if you give them the first dose and 3 to 5 minutes later, you give them the second dose and now you're out, hopefully by the time they need the 3rd dose, the 911 folks are here so they can take care of that for you. After giving them the drug, the Narcan, put them on their side because they may vomit, and so you don't want them to choke on their vomit. When they revive, you should just be aware they may be very unpleasant because they're going to wake up in withdrawal. So first of all, they're going to be confused because they don't actually know what happened. A second ago, they were ingesting a drug and they were feeling great, and now they're on the floor and who are you? And they feel like shit. So they may very well want to use again. You want them to not use again. About 1% of people wakes up really kind of aggressive and angry because, you spoiled their high. So it's another reason it's good to have 911 on the way. I'm going to re-emphasize that they should get medical attention so that they don't overdose again when the Narcan wears off. So try to stay with them until 911 gets there and try to encourage them to go to the hospital. This is what the rescue position looks like. It's literally just making sure that they're breathing okay. So you roll them on their side, use their own elbow and knee to kind of stabilize them so they don't roll back. Again, if they revive, then they're probably gonna be talking to you. But you can have them like that, roll them back to give them the second dose if you need to. Now, in pre-COVID times, I would also be telling you that if the person, if you've given them the drug and they're not really revived and their pulse, they have a pulse, but their breathing is not normal, World Health and CDC and everyone recommends giving them rescue breaths. And I'm assuming you guys all, working in a shelter have CPR training. Right now, we're not telling anyone to do rescue breathing because of COVID. Take care of yourself. 911's on the way. But when things go back to normal, you might really want to consider some rescue breaths every 5 to 6 seconds until they revive. And if they don't have a pulse, then you would do CPR. Okay. This is a summary of the aftercare. Again, they're not going to necessarily know what happened. And if they won't go to the hospital, try to keep them with you for an hour or try to stay with them. Make sure they're still safe. Okay. I'm just going to summarize a couple more things you should know. And one is that the state of Connecticut is trying to get Narcan out there to everyone because we're trying to save lives. There is a Good Samaritan law since 2011. So if you administer Narcan to someone and something happened and they died anyway, or whatever, you are not liable in any way. You are trying to help. Also, the people at the scene of an overdose sometimes don't want to call for help because they may have been using drugs as well and they think they're going to get arrested. you are protected because you're trying to save someone's life. If there's a warrant out for your arrest, that's a different story. But if you were using with someone and to save their lives, you call 911, no one's looking at what you're doing. I want to mention the voluntary non-opioid directive form that it mentions on the screen. And that's really useful, especially for people with a previous substance use disorder history. They may really not want to get opioids even when they're having medical treatment. And they can fill out a form that says, don't give me opioids, give me an alternative form of pain management when they have medical treatment. Okay. So this is where I'm going to ask you guys, I hope you can do this now, to grab your phone and go to a website called norasaves.com. And NORA stands for Naloxone and Overdose Response. This is a free app from Connecticut DPH that we want everyone to put on their phone. When you go to the website, at the bottom of the screen, it usually pops up, do you want to install this app? You install it from the website. And then it looks like the picture on the screen, and every one of those little images, signs of overdose, overdose response, how to give Narcan, I gave Narcan, each one is just something that you swipe through, kind of like Tinder, and you just swipe through it. And so you don't have to remember anything other than, here's the app, it'll walk me through anything I need to do. It also has a place where you can report that you actually used Narcan, because they do want to try to keep track of that when possible. Apart from, administering Narcan to save lives, and asking people about potential suicidal ideation if you think it's appropriate, other ways that you can help are you yourself, your organization, your family, your friends. Make sure everyone's locking up medications when they're not being used. Make sure you're disposing of them using doTERRA bags, which I think I dropped off, or dropping them off at the police station. And take care of your own mental health, especially now during COVID. Get some other training. If you're really interested in trying to do substance use prevention work in your community, I want you to know that every town has something called the Local Prevention Council. You can find the one in your town on our website. And I would encourage you to look at our website, because we have a lot of resources there. And so finally, supporting recovery. It's really important for everyone to know that, opioid use disorder is very difficult to overcome without medication. It's not impossible, but the best outcomes, and by best outcomes, I mean survival, is most likely if people do medication-assisted treatment, and as well as, recovery coaching and wellness and self-care. We've got a couple of resources on the screen. The DMIS Substance Use Access Line, 800-563-4086. That is primarily focused on getting people to detox and opioid treatment, and they can provide transportation when needed. And then those websites at the bottom are the pages that we have on our website at the hub. The treatment page has the resource guides that we hand out all the time that list all the different mental health and substance use resources in the region, one handy dandy guide. And they also include all the recovery resources, which are all the different peer support groups that are out there, all of which are now online. Okay, so that's it. I got close to a half hour, and I want to see if you all have any questions for me.
It was a good refresher. Thank you, Margaret.
Oh, good. Okay.
That was helpful. Thanks, Margaret.
I was just going to say
Thank
that
you.
a lot of the things that were identified as being a problem, it seems as though some of the legislation in Connecticut has addressed that.
Yes.
So, you would go to the doctor for a splinter and you get a 30-day prescription of some opioid. But so I think that is a good thing, and things are changing. It's good to see that some of the numbers did dip a little bit as far as the overdoses. So that's good to know.
I think the
a little scary, I think. Yeah. I always thought it was just a little bit scary to administer the Narcan. And I told the staff about this. I think I bumped into someone who was nodding off at Dunkin' Donuts, and she was just parked right next to me. And I kind of aroused her, and just went on my way. I don't know if she was tired. I don't know, but she responded, and was things fine. And that's always so tricky. If she wouldn't have responded, I guess I would have had to do
you're right.
something else.
If she can talk to you,
So I think it's something that we just kind of maintain an awareness of and be on the alert for. So, but thank you. I thought it was really helpful, very concise.
Good. I'm glad. So at this point, if you're all done, you can get off, but I'll leave the line open for a few more minutes until I see everybody off. So if you have any questions, feel free.
Are you going to send us the slides, these, Margaret, this information?
Yeah, I can send the slides too. And I'm going to send you, well, you know what I'm doing? I made a recording of this, so actually I can make the whole recording of it available if you want. And then I'm definitely going to send a few different resources to you, Paris, if you can just send them to everybody.
Okay, great. Thank you so much.
All right.
Thank you, Margaret. Thank you, Margaret.
Have a great weekend.
All right, you too.
Thanks, Margaret. Be safe.
You too.
Good. That's good.